Welcome to your history take-in presentation. Today we'll be looking at various methods and formulae for obtaining a patient history and document it accurately. So aims and objectives are aim, as you can see below, to progressively develop the ability to obtain a relevant, focused, holistic history from increasingly complex patients and challenging circumstances. Then to record accurately and synthesize the history with clinical examination and formulation of a management plan. So that's quite a mouthful, but essentially you'll be looking at recording a history and making sure we have all the necessary information we need for that history. Our objectives then: to take the history, to document findings accurately, recognize that patients do not present history in a structured fashion. How many times have you asked somebody what's wrong with them and they've told you how it all started in 1964? We also want to have the ability to quickly focus questions to establish a working diagnosis and relate that history to relevant examinations, investigations, and formulate a management plan. So a couple of things to consider. One is SOLA. It's the non-verbal strategy of showing patients that your full attention is being paid to them, and it relies a lot on body language. So we have sit squarely, open posture, lean forward in an attentive manner, make eye contact but not in a threatening manner, and have very relaxed style. There's another acronym, surety. And this allows for cultural variations and appropriate use of touch. So we have S, sit at an angle to the client, uncross your arms and legs, relax again, appropriate eye contact, touch if it is appropriate, and use your intuition. So touch isn't always appropriate, particularly when dealing with members of the opposite sex, and different levels of touch can elicit different responses in people. Some can be quite calming and some can be quite threatening. So before you start, if you're doing paper records, what you want to do is your name, date and time at the top of the history taking sheet. We know these records are being taken constant at the same time as the patient history is being taken. If you're working with electronic notes such as System 1, then all these records are automatically dated and timed, so one less thing you have to worry about. And the person writing the note is automatically identified when you log onto that system. It obviously knows who you are. The trouble with electronic systems, it's difficult to draw diagrams, so descriptions need to be more explicit. A lot of the patient management systems do have some sort of diagram generating software, but it is often difficult to pinpoint like an area of bruising or pain on a standard diagram. So the importance of history taking is obtaining an accurate history, being the first crucial step in determining the etiology of the patient's problem. Often the diagnosis will be made of history alone, and it says a good historian can make up their mind or have 80% of the answers before they actually lay hands on that patient. So first impressions, always a good thing. Would you be impressed about this person treating you? Probably not at this time. So when we engage in the patient, they say our words only make up of 7% of that impression we give somebody. Our body language and appearance gives 55% and our tone of voice 38%. Because somebody might adopt a very uncaring or unsympathetic tone of voice while appearing to have an open, relaxed posture and saying the right words. So first impressions. So here we have a punk rocker, and to some people, I'm sure you're all very PC here, listen to this recording, but a member of the public might consider this person to maybe be a drug user or be violent or be a bit weird, and it all is down to impressions. And this is a very sad story because, as we can see, this is a real person. Peter Williamson, who's a punk rock musician, had a Mohican and facial piercings, and he died from swine flu after various medics in different hospitals assumed he was a drug addict, despite the fact his mother claimed, explained to them how ill he was, her pleas and his pleas for help were ignored, and sadly died. He was turned away from hospital. One nurse sent him home saying, "Do you realise we have sick people in this hospital?" He was also turned away from his local health centre by his GP staff. And the ambulance crew eventually picked him up, asked him if he took drugs, and he said he did not need to go to hospital. So you can see a massive failing in the system by, those poor first impressions. So there we are. Poor lad died of swine flu with secondary pneumonia in 2011. Particularly poignant in this year 2020, which now facing COVID-19. A pathologist said his death would have been avoided if Peter had had early treatment. So try to avoid making assumptions from your first impression, such as old people are deaf or young people don't know what's good for them. So differential diagnosis. Often you come up with a primary idea of what's wrong with this person, but you may have a differential. And the method of differential diagnosis is based on the idea that you can begin by first considering the statistically more probable diagnosis. And an example of this is when you hear hoofbeats, think of horses, not zebras. After the more probable diagnosis is ruled out, consider the less likely ones and form your diagnosis after assessment and not before. So here we have some lists of subjective and objective data. So subjective data being what the patient tells you, so in like a symptom or history. So Mrs. G might tell you she's 54. She's a hairdresser who reports pressure over the left side of her chest, like an elephant sitting there, and the pain going right down left arm. From an objective point of view, we might say that what you detect during the examination is Mrs. G is a 54-year-old, overweight, white female who is pleasant and cooperative. Our observation are as follows. Her blood pressure is 160/80, her heart rate is 96 and regular, and has a respiration of 24. She's also afebrile or aporexic. So now we go on to more the nitty-gritty and look at the general approach. So first of all, you want to introduce yourself. It may be appropriate, depends on the patient's presentation, their particular cultural values, to consider a handshake, although that's not normally required. Determine a patient's desired name. Would they prefer to be called Mr. Smith or John or Jonathan or whatever? Avoid using common slang and potentially disrespectful terms such as love, hate, mate, friend, etc., particularly with people you don't know. And remember your tone of voice. Some people will detect a lot or perceive a lot by the way your tone comes across. Always remain confidentiality or keep confidentiality and respect your patient's privacy. And can the patient be made more comfortable? Depends on what setting you're in, whether you're in a hospital, whether they need to sit up to speak to you, or whether they're in a doctor's surgery and they need to lie down or sit on a couch or something. We need to give good eye contact and position yourself comfortably at their eye level to aid communication. Ensure that there is an appropriate distance, safety, and remember the personal zone. And above all, listen to the patient. So be aware, some people are more difficult to gain history from others. You might have just hit silence, like an adolescent who doesn't talk to anybody, let alone a stranger. They might be very talkative and give you lots of irrelevant information, but you have difficulty getting them down to the facts. They may display some sort of anxiety. They may be crying, may be confused or angry or disruptive. And all these factors could be to do with their personality, their illness, or some transient thing that's interfering with their normal way of communication. There may be a language barrier. It could be they're from Japan, Eastern Europe, France, Wales, wherever. And they might not prefer to speak in English or have very poor spoken English skills. There are various services available, and it's far better to use something like a language line than to rely on a friend, colleague, relative to translate, because they may have not give you the information you need, put their own slant on it, or they may have an ulterior motive for not translating quite exactly what the patient says. If a patient has any reading problems and is presented with any information that they need to read before, say, an operation, then that needs to be considered. We have to consider if they have impaired hearing, whether you need to raise your voice or whether they could have some sort of aid or have the information written down for them. They may have impaired vision and require some other help in that way. Often you find that patients can be poor historians. They're not used to the medical model we use for recording information, and therefore will give us this information we want piecemeal. We'll ask them a question and they'll start talking about something else that we won't be asking them until 2 pages later. But all of these pieces of information need to be drawn together to produce a good history. There may be cultural differences. It might be so a lady from a different culture would be uncomfortable revealing certain details to a male medical practitioner. If there's domestic violence going on, you might not get the complete story of how an injury may have happened. You might find a husband or wife who's the abuser in the room will try and control the conversation. So it's often good to speak to the patient alone, particularly if it's an adult, so you can gain all the information you need. And also consider the patient's mental health. It might be that they firmly believe something's happening, but from your impartial perspective, you can see that their view of reality is somewhat warped or disturbed. So when we ask our questions, we need to keep it simple. Be clear and avoid medical terms. Use open questions appropriately and avoid interrupting the patient where possible. Make use of direct questions, and then after the patient's given you so much information, go back and summarize what they've told you to make sure you're clear in your notes that what you've told them is their idea of what's happened to them. So from a bibliographic point of view, we always need to record personal details such as the patient's name, age, address, gender, ethnicity, occupation, maybe their religion if it's relevant, possibly their marital status, depends on what sort of situation you're in, and the date and time of examinations if this is not electronically already recorded. And if you are using an electronic computer system, then a lot of this stuff may already be pre-populated from the NHS spines. You'll have their name, address, age, etc. Down already. Why is it important to ask about occupation? It might be that they have an illness or injury which is affected by their occupation, or their injury or injury may go on to affect how they perform in their occupation. So to produce a complete history taking, we need to look at various points, and these are summarized below. We have either presenting complaint or chief complaint. You can use one or the other. PC, presenting complaint, is the normal abbreviation used. The history of the presenting complaint, or HPC. Past medical history, PMH. Systems inquiry or systemic inquiry, SE. Family history, FH. Drug history, DX. And social history, SX. And you can see some other abbreviations for them there. Some people use X for history and some people write a H. It makes no difference really. People understand what you're talking about. The bottom one, OE, is your on examination. So when you actually get round to laying hands on that person or doing some observations, what do you find? And as a friend of ours all said, ask the right questions and in the right order. So Columbo here, he was famous for going off on a tangent, and at the end he would say, oh, just one more thing, and he would come up with some startling question, but completely out of sequence with the rest of the interrogation. Not that we'd be interrogating our patients. So our presenting complaint or chief complaint, not always so obvious as this poor chap, and some people might come in and say they're feeling generally unwell, and you find their chief complaint is chest pain or shortness of breath. They might come in and say they think they're having a heart attack, but you find out they've got costochondritis. So it's not always blatantly obvious what the chief complaint is. You may have to go digging round for your answers. There's a good example here of looking underground and finding various nuggets of information you might need to pull out of the patient's story, enable you to form your diagnostic picture. So when we're asking about our presenting complaint, and we'll call that from now on to just to save confusion, you want to ask open questions. So can you tell me the main reasons for coming to see me? What brings you here? How can I help you? What seems to be the problem? Make these questions very general and broad and try and get that initial information through. They may have a single complaint, like a bit short of breath or the chest is tight. Or they may have a list: chest pain, palpitations, dyspnea, ankle swelling, etc. However, they may have a list of totally unconnected complaints: earache, indigestion, ingrowing toenail. And in these times where people might take 3 or 4 weeks to get a GP appointment, they like to get their money's worth. So if they found any little niggles, you might add them to the end of the list. So let the patient describe the problem in their own words. Record it in the patient's own words, i.e. tummy ache, feeling generally unwell or under the weather. Document the presenting complaint in a short, clear sentence on your notes, communicating the present major problem or issue: chest pain, shortness of breath, injury to lower leg, etc. Something about going on from that, you can give it a bit more detail. It might be that they presented with a productive cough rather than just saying cough. They might have been admitted today with a history of abdominal pain rather than just saying abdo pain. Or they might have fallen over their cat and hurt the leg. There's not the cat size. Hopefully. The history of presenting complaint gives us much more detail we can go into, and we can use various tools and things to egg out more information about this. So we describe each symptom as it appears in chronological order. If they've only got one symptom, that's great. If they've started off with a bit of shortness of breath and then developed into chest pain, we can do them in order. It's much more detailed than our presenting complaint and really irks out the little details that we need. So, for instance, complaining of central abdominal pain, which started 2 hours ago, started to vomit this morning, no diarrhea or urinary symptoms, and no risk of pregnancy, particularly if it's a bloke. We might want to know about timing, when it started. Is it intermittent or continuous? Is it recurrent? And do those episodes occur at a pattern? Is it brought on by eating or walking, doing exercise, whatever, etc. So we have a few tools when we're looking at pain, and pain is a common symptom people present with. And people may have a number of other symptoms which they find inconvenient, but when things start becoming painful and they can't manage their own pain, then often they present with this. So we have different tools about how we can assess pain. We're going to look at a few in the next couple of slides. So the first one is RbvIqyxOS0e92dwl0cNx a good acronym, easy to remember acronym, which describes various how we pick up on various types of pain. So onset, when did the pain start? Was it sudden or gradual? Did anything provoke or palliate the pain? What was the quality of the symptoms? What was the severity? Radiation. Does it go anywhere? Don't ask the patient if they have any radiation, otherwise they think they've been near a nuclear bomb. Say, where's your main pain? Does it go anywhere else? Ask about the severity, and this could be scored on a scale of 0 with no pain, 3 with severe pain. Could be ask them to give you a verbal scoring, such as mild, no pain, mild pain, moderate pain, or severe pain. Or it could be a more broad one, such as score your pain 0 to 10, where 0 is no pain and 10 is the worst pain you've ever experienced. It might be worth asking them what the worst pain they've ever experienced is, because if it was previously toothache and now they've got a major limb injury, then that puts things in perspective. And timing. Does the pain vary in intensity, or is there any other feature which is affected by time? So RbvIqyxOS0e, easy to remember acronym, handy way of assessing pain in a bit more depth. So the next one we have is Socrates, and Socrates is mainly used with the medical model, which we've been talking about and using during our examinations. So we want to know the site, where exactly is the pain? The onset, when did the pain start? Was it sudden or gradual in onset? Excuse me. The character, was it sharp, knife-like, gripping, vice-like, burning, crushing? Like an elephant sitting on my chest. What does that pain feel like? The radiation, does it go anywhere? Your arm, jaw, groin, back, wherever. And is there any associated symptoms? Do you feel nauseous? Is there any shortness of breath, clammy, that sort of thing? The T is timing again. Does the pain vary in intensity during the day? And then exacerbating and relieving factors. Does anything make the pain better or worse? Is it worse after you exercise, eat, etc.? Does sitting down make the pain go away? And then severity again, using the pre-mentioned scales. It might be if this person cannot speak or has trouble verbalizing things, or as a child. We might use something like the Wong Barker faces for pain, where they can point to a smiley face or grimacing face to determine their level of pain. So the last one we're looking at is old cart, or in some books you might see this as old quart, where the character is replaced by quality, but old cart's easy to remember. So again, we have onset, location, much like site in the previous examples, duration, character of symptoms or severity, alleviating factors or associated symptoms, radiation, and any treatments tried. So this is a quite good one for old card, but it might be that, I've had this pain for 3 days. What allergies have you taken? Oh, I didn't take any. It might only be a little pain, but why didn't you take any painkillers? And you get learning a lot about your patients that way. So recording the past medical history. Start by asking the patient if they've had any medical problems. Now, medical problems can be quite tricky because lots of people don't consider things they've had for years medical problems, but don't cause them a problem. So it might be worth asking them, are they being treated by their doctor or anybody in the hospital for any conditions? And you're more likely to get a validated answer from that. There's some things we want to know in particular. So have they had any ischemic heart disease, ever had a heart attack, stroke, transient TIA, any diabetes, and if so, when were they diagnosed? Was it an early onset diagnosis or late onset? And are they type 1 or type 2? Any evidence of hypertension, any epilepsy fits, and if so, how often do they normally have seizures, if at all, or is it well controlled? And asthma, particularly with asthma, ask them if they've ever been admitted to hospital, particularly onto ITU with their asthma, and if so, do they carry an oxygen warning card? We also want to know about any COPD, whether they've ever had tuberculosis, jaundice, etc., and any previous surgery or operations and when they occurred. And if you're coming in somebody with a broken ankle or ankle injury, which may be a break or a strain, taking all this information might seem a bit over the top. But particularly if you have electronic medical records, but you don't share things between organisations, recording it now in your own system might help that patient later on where they come in and they're in too much pain or whatever to give you all the information they need. You have it there already. So it's always good practice to go through the whole of the history taking process regardless of the presentation, time allowing. So if we're talking about a minor injury here, have they had any previous accidents? And if so, when and what injuries? It might be they've come in with a bit of chest pain, but we've asked them if they have any previous accidents, and they said, they had a pain in their leg a few weeks ago, which they thought was a muscle strain, so it hadn't mentioned it previously. But now you're thinking more DVT leading PE. So, getting a full history is the key to a good diagnosis and treatment. And have they had any previous blood transfusions? Not so much a problem nowadays, but previously people picked up various diseases from contaminated blood. And if they know their blood group, if you're in a situation where they might need blood given. So recent travel, again, there's lots of things happening in the world, particularly at the moment. So have they been anywhere where there's known viral diseases, high risk of malaria? Have they drunk any water that might have been contaminated and might have dysentery, for instance, or been subject to some parasitic or protozoal disease? Also, if they've been on a plane and we're in the middle of a flu season, then there's a risk of picking up anything from that recirculated air from on board a plane or crammed onto a deck of a ferry, for instance. Okay, so if you do have electronic records, as I mentioned previously, you might not have to go through the whole list, and some of that information would be already available, but it's good practice to double check the patient's still being treated for various things and they're compliant with their treatment and medication. And remember, not everything may be recorded on your electronic system. Here you go. So the next part is our systems review or systemic review, abbreviated to SE. So we begin to assess patients as I should say, whole person from the moment you first meet. Observe the patient's manner and gait. So their manner can tell a lot about themselves, whether they appear to be guarding, whether they're in obvious pain or discomfort. Their gait might reveal how bad an injury. If somebody says they haven't been able to weight bear, but you see them walking into the waiting room but only hop down to the examination room, you know they have weight beared at some point. The patient's mood, it might be that, how ill they are will affect their mood, or it might be that their anticipation for treatment will affect their mood, and they might be disappointed. Do they look their chronological age? So some people look very young for their age, and vice versa. Some people are very old. If somebody's been smoking for a long time, often they have very wrinkly skin, and so looked after themselves, and that can prematurely age people, as well as having certain diseases. Are they well orientated? Are they able to answer your questions appropriately and are aware of their surroundings? And are they appropriately dressed for the time of year, weather conditions, and any problems with personal hygiene? Can add into your picture of that person's social situation. There's a lot of information in here which is given to not to miss anything. It's only a guide, and you would use whichever bits of these were subject to your situation. But any significant findings should be moved to history of presenting complaint if that wasn't previously done, or past medical history. Depends on where you think it belongs. Depends on what order the patient gives you this information in, and sometimes, as I said, this can be very disjointed. So do not forget to ask associated symptoms of presenting complaint with the system involved. So if you ask them about COPD, do you find yourself breathless? Do you have oxygen at home? How far can you walk without becoming breathless, etc.? And there's some series of questions coming up shortly, which will give you some more things to think about. If nothing is found on a particular system, you ensure you document no significant findings to show you did it. And that's the same as when we start doing the examination skills. It's just as important to examine what you did and found to be negative as what you did found to be positive. Now we know that certain things have already been ruled out, particularly if you're referring on to a different speciality or service. So we have some system review questions here. So general questions that you can ask somebody. Have they experienced any weakness, tiredness, weight loss, weight gain, fever, lumps or sweats? So you can see a few things might be coming to bear there. From a cardiovascular point of view, do they suffer with any chest pain? Do they have trouble sleeping at night due to breathlessness? Do they have trouble breathing when they lie down? Are they generally short of breath? If they have a cough, is it a productive cough and what colour their sputum is? Do they have any swellings of their ankles? Have they suffered with any palpitations or have been particularly pale or cyanose and somebody's commented upon it? From a GI point of view, we're looking at appetite again, any special diets, any history of nausea and vomiting, any regurgitation, heartburn or flatulence, any difficulties in swallowing, any abdominal pain or distension, any change in bowel habits, any hematemesis, melena or jaundice. And from the respiratory system, any cough, again, is that productive or dry? Any sputum again, any evidence of blood from spit, any evidence or history of chest pain, shortness of breath, fast breathing rate, hoarseness or wheezing. And then from the urinary system, any obvious frequency, any pain or difficulty passing urine, any urgency or hesitancy, any dribbling at the end when they urinated, any nocturia, any back or loin pain, any evidence of incontinence. If they're thinking about minor injuries, we will look about caudal equina, and anything to do with bowels or bladders, irregular things. It's a good thing to pick up here and should be one of your key questions for back injuries. What's our urine like? Is it normal amount? Are they going little and often or a lot all at once? What sort of colour is it? Is it foul smelling, or is there any sort of bits or discharge in it? And have they suffered with a fever as well? That was a good question for any patient. For the nervous system, we want to know if they have any differences in any of their senses. So any problems with their vision, sense of smell, taste, hearing, or speech. Any headaches, any history of fits, fainting, blackouts, or loss of consciousness. Any muscle weakness, numbness, or paralysis. Any abnormal sensations like pins and needles on in any parts of the body. Development of a new tremor, or any change of behavior or psyche. And then the genital system, again, pain, discomfort, itching, discharge, unusual bleeding, any sexual history we need to know about. Do they have a single partner? Are they promiscuous? Do they have multiple partners? Do they have sex with strangers, etc.? For a lady, the menstrual history, when was the last menstrual period? How long does it normally go on? And any history of contraception. Any chance they may be pregnant? And if so, or as well as their obstetric history. Do they have any children? Have they had multiple pregnancies, but not all of them have produced an offspring, and why? So quite a lot to ask people. And then lastly, again, more relevant to our minor injury patients, any previous pain. Can we elicit whether that pain is muscular, in a bone, or in a joint? Any swelling, any weakness of movement, any deformities that they've noticed, and has it caused any problems with your walking, or if you notice any problems with their gait? So that was the systemic inquiry, quite a lot there, and I'm sure you could think of a range of other questions as well. So now we're going to move on to drug history. So this is to establish what medications a patient is taking. So that's prescribed medication, over the counter, anything they bought herbally, maybe any illicit drugs, and if there's a sports people member, they might be taking some sort of supplement for to build up muscle mass or improve their performance. Do we know if they're allergic or sensitive to any medication? And when you're recording medication, always best to use the generic names rather than a trade name, because a patient might tell you something, a name of a drug, and you think, I have no idea what that drug is, but then you find out it's quite a common drug, but they're using a trade name, not a generic name. What dose, when they take it, how long they've taken it for, and if they take it as prescribed. That compliance concordance thing, whether they are actually taking their medications as prescribed. So we might want to say, for instance, instead of putting Losac, we might put ranitidine, 150 milligrams, BD twice a day, PO per hour. So easy way of recording medication. So as in the previous example, we want the name of the medication, the dosage form, the amount, how they're taking it, by which route. There is something like 126 different routes somebody came up with. Ones only, half a dozen of those are quite common. The rest of them are quite bizarre. But there's plenty of ways you can get medicine into your body. How many times a day are they taking them? Any specific times where they have to take them? Is there any specific instructions, like take an hour before food with a large glass of water and make sure you're standing or sitting up, not lying down afterwards? Do they comply with those regulations? Do they know why they're taking the medication? You might get the answer because my doctor gave it to me, or because I went in with this. And it's, they might have gone in with a bit of chest pain and now on the antihypertensive. So it's not directly related to their presenting problem, but it's, it's related. So the patient may come with a list of medication, but they may not be taking them all. So some things they decide not to take. The classic example is people are very non-compliant with taking diuretics because it makes them go to the loo and it's inconvenient. Yeah, well, there we are, go figure. So just make sure they're taking them as prescribed. And if they're carrying with swollen ankles and not taking the diuretics, then we know why. So other questions you may want to ask: have you recently started any new medications? And this surprising amount of hospital and GP presentations are actually caused by medicine reactions. So people are either are taking antihypertensives and now feeling quite faint and dizzy because they're too strong for them, or they might have a side effect of the medication, like they've developed an itch or something like that to do with their medication. So we also want to know, has your prescriber changed the dose or stopped any of your medications recently? Because that might have a bearing on their presentation as well. If somebody was taking something to stop them becoming dizzy and now they've fallen over and injured themselves, then we might want to contact that prescriber and get that information, that medication restarted. And did you change the dose or stopped any of your medication recently? Because some people just don't take the medication as prescribed because they don't like the effects it has and therefore just stop taking it. So why do we ask these things? So as I said, medication may be the cause of presenting complaint. What they're taking may preclude what you can give them, regardless of whether you refer to another service, give medication in the PGD, or are a prescriber yourself. It limits the choice of what they can have. Somebody coming in with a muscular injury shouldn't be advised, say, to take ibuprofen if they have a history of asthma where non-steroid anti-inflammatory drugs cause wheezing. So we need to know they're asthmatic, they have had a previous reaction to them, and therefore we know not to suggest or prescribe that medication. And if the person is admitted to hospital, they may to continue their current medication. So when the hospital will need to know, have they brought all the medication with them, or if they haven't, what they need to supply them in that period of admittance. So some additional questions to explore on the effectiveness and compliance. So I've already mentioned this really. Are any of the medications causing side effects, which the patients are now either they know it's from the medication or they think something else is happening, but it's causing them some distress? Have you changed the dose or stopped any medication because of unwanted side effects, already mentioned? And do you sometimes stop taking medication if it makes you feel worse? So, things to consider. So moving on from drug history, we're going to now look at familiar history. Do they have any familiar diseases? So any history of breast cancer, ischemic heart disease, diabetes, hypertension, schizophrenia, developmental delay, or asthma in the family? So good things to know, might limit your diagnosis down. And say a young person presenting with chest pain might only be a bit anxious, but they've come to you because their father died at 54 with chest pain, with a heart attack. So, need to be considering these things. So other family history, depends on how old these people are, whether their parents are alive, are they healthy, and if they have died, did they die of old age, or did they die of anything particular at a younger age, which might have a familiar history. Same for siblings. Do they have any children? And then whether any of these things run in their family: heart disease, hypertension, stroke, asthma, or diabetes. So moving on again to social history. Do they have any smoking history? Are they a current smoker? Have they smoked in the past? How much do or did they smoke? How long? And if they have given up, how long ago did they give up? Do they drink? That's alcohol. How much do they drink? How often do they drink? How long do they drink for? What type of alcohol they drink? And their drinking habits. Do they drink every day? Somebody who drinks 20 units every day is going to be dependent on that alcohol. So things to consider as well. Do they have excuse me, are they currently working? They have any social or educational background? Do they have any family social support? What's their financial situation? Again, it gives us more of a holistic picture of this patient, not necessarily in every case or consultation. So then we go on to our OE, on examination. Findings from an examination might be positive and negative, as I previously said, and it's just as important to record pertinent negatives as there are positives. Come up with your initial diagnosis, consider differentials, and then make a plan. And that plan might be to go on and collect more evidence. It might be to take some observations, to perform a physical examination, send them some sort of investigation. Then afterwards, that might either inform or change your diagnosis and therefore your plan. So remember, patient's notes are a legal record of treatment. So we need to say what was provided and what was omitted. So that's particularly crucial when recording pertinent negatives. I can't say this strongly enough. All information must be documented precisely and accurately, and must be signed and dated. If it's not documented, it was not done, even if it was negative, and if you didn't ask about it. So always document everything you asked about or perform any tests you performed, whether they were positive or negative. So Sir William Osler, some time before 1919, said always listen to the patients. They might be telling you the diagnosis. And even if you don't know themselves what's a diagnosis, those clues will give you that 80% chance of forming your diagnosis before you even touch the patient. If you've got any questions, please email me or post on the discussion forum. And thank you very much for your time.